Good morning, everyone. This is Paul from VITA. Welcome to another VITA Learning webinar. We have Mark Wagenseal with us today, and he's going to talk about Class 3 removable dentures. We're very privileged to have him and his expertise. Before I turn it over to him and let him get started, though, we'll do a little bit of housekeeping here. There's quite a few of you today, so your phones will be on mute. But if you do have a question during the meeting, please use the question box over here. I will be monitoring the questions, and I will try and keep an eye on those and then ask them for you as Mark's going along so that we can kind of keep up with that. We will leave a little bit of time at the end for extra questions, but a lot of times it's easier just to do them kind of as we're going along. So if you do have questions, type them into that box. Also, I know you guys always ask about your CE stuff. You will get CE for this. You should get an email. What is today? Thursday, probably the 1st of next week. You guys will get an email that will have your CE information and a copy of the video or the recording of this webinar. So look for that 1st of next week. And yeah, if you guys have any other questions, yeah, type them into the box, let me know. And give me a second and we'll get this turned over here to Mark.
Okie dokie.
There you go.
Nice screen.
Thanks a lot for joining us today, Mark.
Hi, Paul. Good morning. Awesome. Thank you very much. My pleasure. Good morning, everybody. Thanks to VITA North America and for Paul for being the hallway monitor today. Thanks, Paul. Woot woot. And good morning. Thanks to VITA North America for supporting our profession and our industry. Again, appreciate it and appreciate the work that goes involved in getting these things organized. So again, thanks to VITA North America. And thanks to everyone for joining, all of you. So good morning, and thanks for taking a moment out of your busy days to hear me flap my gums. Get the reference? Flap gums. So hearing me out and running through a Class 3 bilateral prognathic crossbite. So a real fun one. And we're going to do a little bit of a PowerPoint presentation here, and then I'll walk through and demo the setup for you. This is a preview. We do have a hands-on course, a webinar hands-on course, October 18, 19, and 20 for this exact setup. So if you're interested, you can go on to VITA North America's website and sign up. It is a limited number of attendees. We will send you the case, you will articulate it, have it ready, and then we do a private webinar where I walk you through the setup bit by bit. So that is October 18, 19th, and 20. So this is sort of like a teaser. So again, really appreciate you taking time out of your days and investing in yourself and for our end goal, which is our patient. We are trying to be superheroes for our patient and superheroes to them, whether we see them directly or not, whether we're a direct care practitioner that touches the patient or a technician in a laboratory that builds the appliance for them, we are affecting someone's life. And I appreciate you taking time to better yourself and to be that superhero and that unsung superhero for someone. I wanted to run through a PowerPoint quickly to just talk about some theory so you understand then when you see me set the teeth up, why I do what I do. So Class 3 crossbite is complex patient treatment, especially bilateral crossbite. We consider it complex patient treatment. It's not often taught and reviewed. And our common issues that we face with dentures in general are denture teeth chipping, breaking, and popping off. The patient can't chew well with a new denture, so they just say, I can't eat. And we look at them and shrug our shoulders. Some of the questions I like to pose to someone is I said, okay, Mrs. Smith, would you be as descriptive as you can in your own words to tell me what does not eat or not chew well mean to you? Can you describe it, please? And you want to hear how a patient describes it in their own opinion. It's like me telling you, trying to describe the color yellow to someone. You want to hear from their point of view what's happening. Typically, what you'll hear from a patient is they're going to say, it doesn't work. It doesn't mesh right. It doesn't function. And it's as descriptive as they can be, but what it's telling you is when they try to go through a chew cycle, it doesn't function and work for them. So these are important things to try and find out, because then that's going to help you treatment plan the case to say, how am I going to, what do I need to rectify? What do I need to correct? How am I going to treatment plan this case so that it functions within that person? We hear comments about the new dentures are more loose than the old set, so the old set fit better. So that's always a fun one to deal with. Multiple relines on a case with no success. Of course, the denture base fracturing, pardon me. Food collecting under the denture, but you don't necessarily need to reline it. New dentures are feeling too big. Soreness, of course. The average adjustment rate is 2 to 5 times for an upper and lower denture. And we gloss over this in our professions. You have to appreciate, you can expect that denture patient back 2 to 5 times. So what does this mean for a direct care practitioner? So when I have a denture patient walk in my office, I'll expect them to come back 2 to 5 times afterwards for adjustments. So number one, you don't typically charge for adjustments, so now that's free. Number two, an adjustment takes anywhere from 20 to 30 minutes. You have to then, you're not making money and you're not being productive while you are seeing that patient. And that patient is back 2 to 5 times, so it's tying up chair time. In a dental office, then you also have the cost of the doctor and his staff, his assistant that is assisting him doing the adjustment. They have to clean the treatment room after and all of the equipment. It's expensive to have an adjustment. If we can drop our adjustment rate, this makes us, number one, more effective, more efficient, which is good, and it's less stressful, because adjustments are stressful because someone's in your office because they hurt or it's not working, and it's not working on a new product that they just bought. So you have to think of it like this, like I just buy a new car and then it ends up in the shop a month later. I'm not so happy. Now, granted, denture patients usually understand this and they know they're going to get sore spots and ouches, or owies as I call them, but if we can reduce that, we become more efficient. The patient is happier because they say, geez, you made me teeth and they didn't hurt. And that's awesome. They will tell people and they'll be your advocate for that and for your office. And that also spills down or spills over to the lab, where then the doctor says like, oh, the lab's doing their job. They're building teeth that fit. So this is good. It promotes everyone. So an adjustment is expensive. You have to think, if you do anywhere from 1 to 4 adjustments a day, that's already 2 hours, or you squeeze it in and the practitioner's not having their lunch. So, you know, having lectured and having seen what adjustment rates are for practitioners, I mean, it's depending on the size of your office. I've seen practitioners do anywhere ranging from 2 to 20 adjustments a day, depending on the office and the size of the office. That's a significant drain on your resources and your time and your stress level, because you're always dealing with these repetitive common issues. So today is also about trying to address that, be more efficient, drop that adjustment rate down. That's marketing, and that's promoting your office, and that's being that superhero. Another common issue, of course, is the temporary denture preferred over the permanent one, where they liked the temporary one better. So these issues, as I said, cause us stress. And now it's complicated with a class 3 jaw relationship. So crossbite is a form of malocclusion where the teeth are more buccal or lingual in position. We call it malocclusion in dentistry because we consider it not normal. So the tooth is either too close to the teeth or the tongue than its corresponding antagonist. So in other words, it's a lateral misalignment of the dental arches by medical or dental definition. But isn't it interesting how nature finds a way? So I'm going to be corny for a minute and say Lady Gaga said it right. Baby, you were born this way. Well, guess what? You are. So here's a crossbite situation. This was a young lady that took one of my courses, and she consented to some intraoral pictures, not of her face, but of her dentition. And when you looked at, you know, having met her, she's a beautiful young lady. Yet we look at her mouth and go, well, geez, look at the misalignment here. And you can see the crossbite. But when you saw this as her whole face, she was a lovely young lady. And so you have to see what nature did. She still can chew. Her temporomandibular joint is smooth and functions. She can speak. Yet look at how the teeth have aligned themselves into position. And that's what we're going to review today and concentrate on, is this alignment and the flexibility of alignment. Typically when we set crossbite cases, we do the crisscross method, where the lower right goes on to the upper left, looking at it from our perspective, and we crisscross it. So the bottom teeth end up on the top and the top posterior teeth end up on the bottom. And to me, it's unsightly. It doesn't look good. It's a lot of grinding, and it's just extra effort and stress for us to set that. We're going to go through a process today where we don't do that. I'm going to show you that it's going to look good. It looks quote unquote normal, yet it's in crossbite, and it's going to achieve the function goals that we want, and thus reducing our adjustment rate. So nature finds a way when you look at these situations, and especially now, I'm just going to grab my little my laser pointer here. You can see here we have crossbite, where the buccal cusp of the second premolar is in the distal fossa. Yet look at the first molar; it's in more of a classic arrangement of non-crossbite that we're used to. So what nature has just done is nature's put a different cusp in a different fossa based on the development of this. It's actually quite interesting. All nature did was just change the cusp orientation around, which is actually, well, smart and phenomenal when you think of that. So when you look at her mouth holistically and you see some of the wear patterns on it, she has a slight wear here in the front, but when you look at her posterior teeth, you don't see a lot of wear on them. There's not a lot of wear facets. I mean, look at her tapered mouth. But when we dissect this and we think, geez, but when you saw her as a whole entity, everything fit and the word is golden proportion together. So everything fit for her. So you look at these pictures of her mouth, and there's not a lot of any discernible wear facets here on the dentition. So what's that telling you? Well, it's telling you that it's working. She's not grinding and bruxing to make this work. It's functioning because it's not getting damaged. So these are considerations for crossbite. So again, we have to do crisscross method. We're using denture teeth that typically aren't designed for crossbite, and it's stressful for us because we have to grind it into position. Again, it's different and contraindicated, so we're not used to working on it. And it's not often taught, lots of grinding, etc. So this is about now looking and assessing our patient and their facial form and the frame that the denture is going to fit in, and as well as the movement of the mandible, because typically with a class 3, it's prognathic. So you want to watch the jaw movement. There's not as much movement because the lower jaw is larger. So the muscle structures are typically stretched a little more. So you don't see a lot of posturing as much. We want to consider our speech indications in the tongue. And from a dental technician's perspective, it would be wonderful if the doctor could send you pictures, please, or a video of things, or a video of the wax try-in, anything to help you make your adjustments or your fine tunes a little bit more customized to the patient, and just to effectively build a better fitting appliance. And then you also have to ask yourself, what's the patient's normal and should you alter it? You know, we do, and we've seen that, and through my journey have seen work orders where the doctor says it's crossbite, but don't set it as such, or we try to hide it. And again, I circle back to Lady Gaga. This is how you were born. This is this patient. So why would you want to change them? What right do we have as a practitioner to change them? And what's our goal? Are you just saying don't set it in Crossbite so that it doesn't look bad because the doctor also doesn't like the crisscross method? Well, now you can present a new option and say, look, we're going to set it in Crossbite, but I'm going to set it without the crisscross method, and you're going to see that it's going to look aesthetic when we're done. And that's my point by these words, is to say, this is the patient's normal. Who am I to say you're abnormal, or the textbook tells you you're abnormal? Look, you're Crossbite, whatever. We're going to set the teeth and we're going to make it work. And now I find these cases non-stressful for me. They're not that a mountain of a challenge for me based on what I'm going to show you today. So freedom and centric. This is for VITA Lingualize, Physiodens, and MFT only. So what is freedom and centric? It's a flat area in the central fossa upon which the opposing cusp comes into contact and permits a degree of freedom in before eccentric movements. So that means if you touch your teeth together right now with your own natural teeth and you try to touch them together and wiggle them, you should be able to do it before you slide on the guiding planes and go eccentric. So it's a little bit of wiggle within centric. That's called freedom, and freedom is good, everyone. We have freedom in our natural dentition. Why? Well, so that we don't hit and slide into position. So this is what it looks like on just one tooth. So what I did was I'm showing you here. You can see how it wiggles within centric. Now we're doing eccentric movements, and now I'm going to go back into centric and wiggle it within centric. So there's a permission of a little bit of wiggle room within centric. Why is that important? Because you are asking a denture patient to bullseye land centric every time. That is not possible, because we have to remember, with a denture, there is no nerve into the denture teeth. The patient can't feel their denture teeth touch. Myself, with natural dentition, I feel my teeth touch together, so I know if they're touching properly. That biofeedback's going back to my central nervous system, always saying, yes, Mark, this is where your teeth touch. And so if I get a raspberry seed caught between my teeth, gosh, I know it right away, and then that affects how I bite. And I can tell if there's a misalignment. We tend to forget that a denture patient can't feel that. They don't feel if there's a hit and slide. And so we expect that patient to bullseye land centric every time, because we do that on the articulator. We're using denture teeth that also have that concept in play that they have to bullseye land centric. So what happens is it's not possible. So then there's a hit and slide, so that when the patient's trying to chew, then they come into centric on the very final closing of the cycle, they slide into position, yet they don't feel it happen. And this was my aha moment when I started to realize, why am I having problems? Why can't the patient eat or chew? Why is the denture base cracking? Why is this thing not fitting? Why am I relining it 3 times in 3 months? It all came back to, although when I said bite together in centric, they landed and the bullseye landed centric. Yeah, your centric was fine. My bite was right, but we don't chew in centric, everyone. This was my aha moment. The aha moment is when they go through a chew cycle and land into final centric contact, they slide into position, and you can't see that happen. They can't tell us it's happening because they don't feel it, because they can't. Most denture teeth that we use on this planet do not have freedom in centric. There is only a handful of denture teeth that have and permit that degree of freedom in centric. That was a shock to me when I did research and found that out, that there's only a handful of teeth that have that ability. And when I started to incorporate freedom in centric into my practice and into my dentures that I construct, my adjustment rate plummeted. And I'm not as stressed out with adjustments every day like I used to be. So these are regular contact points of a class 1. So the red dots are where the main chewing cusp is going into its corresponding fossa, the fossas highlighted in black. So the main chewing tooth is the part of the chewing tooth here is in red, and its corresponding contact within the lower is the black dot. The green dots are what I call the freedom cusps. So it's buccal upper, lingual lower here for lingual form. And these are the cusps that help hold the food on the food table to get crushed. So the red dots are there to crush and mince the food into the fossa where the black dots are. And then when someone's going through a chew cycle, the green is where there's no contact, no hit and slide. So that was an outline here to show you of the contact points of lingual form. These are now the contact points in a class 3 crossbite. So what happens is we're just going to flip it. So now instead of the lingual here having being the cusp that minces or comes into the corresponding fossa, it's the buccal. And all we're going to do is just place the buccal of the tooth into the fossa. So we're not going to crisscross it. We're not going to flip it. All we're going to do is just go from a lingual to a buccal contact. Now, the consequences of that are the buccal contacts or the buccal cusps are thinner. The lingual now, the freedom cusps become larger. So we sometimes have to touch these up because, again, that's where we're going to get the hit and slide. But this is going to look aesthetic in the mouth because we've maintained the upper teeth on the upper, the bottom teeth on the bottom, and it looks pleasant and aesthetic in the mouth. So this was, again, another aha moment for me in regards to setting teeth to say, okay, all I'm going to do is just flip the cusps over. And so now it just becomes way less stressful, far easier, effective for me to set it up from a time perspective. And what happens is remember, the freedom and centric part is always in the fossas of the teeth, not the cusps. So this side-by-side comparison just shows you regular contacts to crossbite contacts. All we're doing is flipping. That's it. And I'm just flipping the uppers over and I'm just moving them lingually, essentially, versus buccally in a class 1. So if you have any questions along the way, please contact and write it in your message box to Paul, and Paul will interrupt us and I'll answer questions as we go. So this is now the standard setup with our dots, and this is the crossbite setup. So now what I wanted to do is to take what the tooth was on the card and now show you what it looked like from a side profile here. So we have an irregular class 1 here on the left. The cusp sits in the fossa. Our freedom cusps are in green. But on a crossbite, all I'm doing is now just putting the buccal cusp in. We just have to watch here on the lingual cusp, like I said, that's where we kind of get some of that hit and slide during the chew cycle. So I'm typically just taking away the guiding plane here to promote a little bit more freedom. But the main chewing aspect is going to be here, red dot over black dot. Okay, and that's all essentially simply in a PowerPoint presentation is to show you the difference. And again, my aha moment when I said, look what lingualized occlusion teeth can do without even being quote unquote lingualized occlusion. And the freedom concept, it was amazing to see the difference and the simplicity through the complexity of the theory, if that makes sense, to help one and help me help a patient. So it's important to understand that VITA teeth are designed like a mortar and pestle. So again, that red goes into the black and it acts like a mortar and pestle type of design. It's there to crush food. One of the other biggest complaints that I received, especially during the beginning part of my career, was patients telling me they couldn't eat or chew lettuce. And that was a big one. I've eliminated that problem from my practice 100% by using lingualized lingual form teeth here. And this concept, because the teeth crush the food, mince it like a mortar and pestle, where I found, for example, 20 or 30 degree teeth doesn't do that because it's not the same type of design. They're designed more of a milling action because you have to have them work in balance. And then they're losing the effectiveness because they don't have the freedom and centric. they're locked together in centric. And so then that was again the root of all my problems, when I acknowledged to myself that I have teeth that can wiggle in centric, but now I have a sharper mortal and pestle type of design with the occlusion. It still will function like with working and balancing like I was used to. It was just modified. And again, as I said, it significantly dropped my adjustment rate, which is why here I am today trying to share this to help a profession that I love grow and be those superheroes to patients. And again, creating that efficiency and less stress. So these are the representatives for VITA North America to contact. Paul will go through this after as well. So then you'll be able to pause the video. So now I wanted to kind of go through and show you I'm just going to click out and set the teeth up for you now. I do apologize, so if you just give me a quick moment here. I want to show you this. So I'm just flipping to a different okay. So again, this is a chew cycle. So slideshow, current slide. Watch this patient. So when she was speaking, do you see her lower jaw posture? So it's posturing inside the envelope of her function limits. She has an upper and lower denture. And what I'm having her do is say the days of the week and the months of the year in English. And then if they have a second language, you have them say the second language as well. What the days of the week and months of the year does is it covers the phonetics of that language. So the phonetics are the building blocks of the language. So it's how the jaw and tongue position themselves to be able to pronounce and say the words. And that's what we want. So that covers that, so that I'm watching the jaw posture. So typically on a wax try-on, we're looking at midline and smile line and color and all the aesthetics. Now I've trained my eye and retrained my eye to look at the function. So what that means now is when she's going to chew, she's also going to chew with that type of cycle. So I know she postures out to her left. So then what happens is when I do this setup, I can clear more of the guiding planes because I know she likes to swing out to the left. So I'm grinding the upper guiding planes on the left side a little more. She still lands in centric. She still has freedom in centric, so she doesn't have to bullseye land it. But now I'm clearing things out on when I craft the setup so that she can function without hitting. And this is her denture. I buried it. We have 6 or 7 millimeters of overbite on this thing. It shouldn't work, but it does, because again, my aha moment in all this was to say, I can challenge myself now with an understanding of freedom and centric and a chew cycle on these cases to now craft things that I never thought were possible. And this is what she needed. So it looks like this, yet when you put it in the mouth, it functions like this. So it's not, although it's a buried overbite case, it doesn't present like it, because now I've identified how she's functioning. So if you can get videos and pictures from your doctor, that would be most helpful, if that's possible. And as a direct care provider, all those that are watching, start to look at the function and the chew cycle of your patient, because this is what's going to help you identify the issues and identify how you want to treatment plan the case and set the case up. So I was able to challenge myself and challenge what I thought was possible, and not get scared by it anymore or consider it a geez, this is going to be hard type of response. So bear with me. Okay, so we have a bottom, we have a top. So, and then again, the cusp sits in. So as we had discussed before, freedom in centric is that little bit of freedom within centric, because now the tooth goes through a chew cycle like we've identified. And what we don't want to have happen is the hit and slide. So the hit and slide usually happens on the guiding planes here, where it'll come in and slide into position. Because remember, there's no nerve to denture teeth, so the patient can't feel that happening. And again, they land and I go, oh yeah, their centric's great. You know, bite, close, bite, tap. And oh yeah, their centric's great. Well, yeah, because it's not functioning. They don't chew like that. When they chew, there's a cycle and it looks like a teardrop. And that's where the hit and slide comes. So I wasn't asking the right questions clinically to identify that there was a hit and slide. I was just saying to the patient, touch, close, tap, bite. And I'm looking at it going, well, my centric looks great. And the patient's like, yeah, well, I can't eat. And it's like, so then again, my aha moment to say, wait a minute, Mark, there's a chew cycle. And now I've taken steps to identify said chew cycle so that I now know if they posture and swing out to one side, I can adjust this guiding plane more because I know they favor this side to allow that jaw to swing out in that direction. So all we're going to do now in a crossbite is all I'm going to do is flip it. So instead of putting this cusp in the fossa, I'm putting this cusp in the fossa. That's it. And then I'm just watching because remember, this is a larger cusp. So I'm probably going to have to grind the guiding plane up here now a little bit to compensate, just because now I'm not using this cusp as designed. I'm using this one in a crossbite case. But what this does is this maintains the lower, the emergence profile, the aesthetics. The upper also maintains the emergence profile and aesthetics like this. So when you look at it in a smile or in a mouth, it looks quote unquote normal. It's not reversed where I've got the wrong teeth on the wrong arches and it looks terrible. It looks like when the patient opens and closes that there's a regular dentition in there and it hides the crossbite. Patient doesn't pick up on it. Because remember, we're just trying to find that little triangle, that black triangle, and it starts to disappear right around the second premolar. So back here on the molar areas, I can achieve this type of contact and you don't see it. So all we're going to do now on a setup is just do this. I'm just putting the buccal cusp in the fossa. And that's, you know, as simple, I suppose, from a word perspective and a chatting perspective to say what we're going to do. Okay, bear with me because I got to make room for this. Okay, so let me just turn the light off. There we go. And do this. Okay, so this is class 1. So we have what we discern in dentistry as a normal jaw relationship, normal joint relationship with normal muscle. Class 2, we now see that the lower jaw starts to retrude. Typically then we have a tighter orbicularis oris lip, and especially tighter right in that area here. So it becomes an issue for the lower denture because the muscles down here are tighter and dislodge the denture. Class 3, we go in now with the jaw protruded out. So typically now we're stretching the back muscles here a little bit more, and there's less space along the pterygoid muscle groupings because the jaw is thrust forward. And so that also plays a factor here. So from that perspective, again, class 3 is more out and forward, so it stretches that muscle grouping system than a regular class 1. Class 3 is kind of, you know, more out here So depending on the joint, we also can expect that depending on how the person was developing, where the disc sits in relation to the head of the condyle. The only way to know that, of course, is through MRIs. So we have to kind of watch that. It's interesting if you can see MRIs from that, just to see where this sits. Typically, what we're going to find is that, again, it is a quote unquote normal relationship here because the joint does have to function. But we see that the teeth in the jaw just overexpanded compared to the top. So that's why we just have to watch during our setup technique. Okay. We have an upper and lower. We flip it so you can see. So, okay, we have it's a crossbite. Okay. Prognathic. So what I'm going to do is just get some wax, heat it up, set some teeth for everybody so you get to watch me work. And what I wanted to do, so thank you for your patience while we wait, while I heat things up and do things. I wanted to do this live and not have it preset. The thought process on it was, I wanted to have you watch me work, but what it does is it just shows you a better an understanding of the approach. So bear with me while I do this. Now, because this is just a demo case, I'm just using a regular setup wax on this just to facilitate a bite rim and setting the teeth on. I do not use this for patient cases. Actually, what I use is a hardened wax as my base plate. I do not use a light cure or such. I just sort of migrated out of the shellacs and I've just got into the hardened wax. The reason being is hardened wax emulates a denture base better. Shellac wood as well because it's just smooth, and I'm trying to emulate the denture that's currently in that patient's mouth so as not to confuse the central nervous system. All right. So for today's demo purposes, I want to spend more time on the function of the teeth. What we're going to do is I do a model analysis on the denture that tells me, again, using anatomical landmarks, where I want to sort of set denture teeth. But for today's case, I'm going to forgo that a little bit because I just want to get more to the function end of things for you. So forgive me as I'm not going to spend as much time making sure that I'm 22 millimeters down from the sulcus on the top and such things that we would typically do while setting teeth. So I want to show you the nuts and bolts of this within our short time frame today. On the hands-on webinar course, we'll dissect everything and model analysis everything, and we have the time to do that. So I appreciate your patience. and understanding on that topic. So for this case, and for the case in October, we're using VITA Excel, VITA Pan Excel, anterior teeth, and lingual form posterior. The posterior, yes, Paul.
Can I jump in? I've got a question here. They're asking, what is monoplane neurocentric occlusion, and why do you apply this to a denture patient?
Okay, can you say that again, Paul? Because you cut out a little bit on me in my ear. What is monoplane? Paul?
What is monoplane I'm sorry. Let me try this again. Monoplane neurocentric occlusion, and how and why do you apply this to a denture patient?
So they're asking, what is monoplane neurocentric occlusion?
Yes.
Okay, I don't have a proper definition for you. My apologies. I don't have a proper definition for you off the top of my head of that, because to be quite honest with you, I think that's one of the few times in my career I've ever heard of that. So my apologies. I'm going to get stumped. But Paul, can you just send me an email with that down, and I'll have to do some research after the fact on that?
Will do.
I don't incorporate that concept into any denture that I've ever built. So that's a great question. Thank you very much, dear colleague. But I don't have an answer for you to explain it, other than I would only have to guess, and I don't want to do that based on what the words are meaning. However, I can tell you now, I do not use monoplane teeth at all, ever in my practice, ever again. I used to set with mono teeth, but I do not do that anymore. And the reason being is monoline teeth are flat-based teeth. You need to have treadwear to eat and chew your food. It's like driving with bald tires. You don't handle that well and corner that well and have grip on the road. If you give someone monoline teeth, it's the same problem. They're not able to chew their food properly. What cusped teeth do is it gives you that treadwear to chew. But remember, we were using monoline to say, oh, you have freedom and flexibility. Remember, there's freedom and centric in these teeth, so it's built within the tooth and within the treadwear to have freedom and flexibility. So that, again, when they chew and they go through their chew cycle, which is that teardrop, I'm not having the hit and slide, even with cusped teeth, because of the freedom and centric compensates for that. Whereas with denture teeth like monoline teeth, they're flat-based, thinking that was going to solve the problem. Well, sure it did, because you just cut all the cusps off. So yes, it solved the problem. What it didn't solve was the fact that now they're trying to chew on flat teeth, which is not effective. And how do you mince food? How do you grind it when there's no tread there? That would be my comment to this. So I'm gonna have to do some research on that. Thank you for the question. What I did was I said, yeah, go ahead, Paul.
I'm gonna forward that one over to you so that you can follow up with them. I also have another one here that's a little longer and fairly intricate, probably out of the scope of this particular webinar, but I'm gonna forward that over to you also so you can follow up with them offline, okay? So, and that's for DPAC. So I'll have Mark follow up with you on your question. And then also Ryan, I'll forward that one over to Mark so he can follow up with you with that one as well.
Huh. those names, I might even know who these people are. Then fine, I'll follow up with you privately. Just thank you, Paul. Send me the questions and I'll look after it. I apologize, you guys, because we are on a little bit of a clock here, and I'm trying to stick within confines of our time. That noise you heard is my phone, so I'm just making sure that if I'm getting a text from it, some people have my number, so I'll just keep an eye on my phone. I like answering questions like this as we go. So what I've done is I've set 6 anterior teeth. I've set the first premolars or bicuspids, and now I've set the lower while we were chatting. So the lower first bicuspid. So what I'm doing is I'm setting my compensating curve, occlusal plane, and typically what we'll do is you'll see from this perspective, we've got the distal cusp and the mesial cusp come together, and it forms a triangle. So let me just, out of focus for you, let me just touch this up a little bit better. There we go. Okay. Refocus. Refocus. There we go. Okay. So I'm creating that little triangle, which tells me that it's at the right height and positioning. So that's establishing my occlusal plane here. So I'm going to concentrate and set the lower teeth first for this case. I'm doing that so that I can stay over top of the model analysis and my zone of where I want to set the lower teeth. So that's done with intent. Paul, are you there?
Yes, sir.
You're going to email me those questions, Paul, and then the person's contact information. Awesome. Thank you for that.
I'm gonna email you the questions, and then I'll also follow up with their contact info and stuff specifically. I'll get it off of the register.
Yeah. Okay, thanks. I apologize, everyone. But thank you for the questions. I'm curious about the intricate long question though, Paul.
They're asking about patient that suffered a severe cerebrovascular accident and has a permanent alteration and deviation of the face, along with stroke-induced facial mastication means
Paralysis.
muscle.
Yeah.
So
okay, so there's no rule book to that one, everyone. What you're trying to do then is to try and find centric. The best I can offer is I have, in these types of situations, I build a very specific type of rim, and then I warm the bottom rim slightly so that the top edge of the wax is warm, and I have them take a glass of water and swallow. And what happens is when you swallow, it physiologically you find your best centric. So if we have paralysis and such going on, I have to find where they typically swallow and is it reproducible. So I'm looking to see actually in the treatment planning stage, can they reproduce centric with the dentition or the denture that they currently have using the swallow technique with water. And then when I'm capturing that to craft the denture, I have them drink water again, swallow water so that when they swallow, your teeth come together as part of the swallowing process. And that's when I try to capture their specific centric. And then because of then I'm going to determine their function limits, the paralysis and do they posture and such. based on the days of the week, months of the year. I might even have them bring in food to eat with their existing denture so that I can see what kind of movements they have. And then when I craft the denture, fine tune it to those movements and those idiosyncrasies with this type of occlusion, because now I really want it so that it's efficient and effective. I want those cusps mincing the food with as little chews as possible so that it's done, and I clear the guiding planes so it functions within their idiosyncrasies of their movements. So how's that for a quick answer on a complicated question? So this is about customizing it to the patient. So what I've done, everyone, is...
Yes, good answer.
I get one a day, Paul. You're going to ask now, okay, Mark, what did you do? Well, I set up all of the lower teeth already, and it's in Crossbite. Our junction point on the Crossbite is going to be the second premolar or second bicuspid. What I've done is I've set this flat plane. You don't have to. You can actually set this on a curve. So if you're used to setting a 20-degree curve, that's fine. I set it flat because there is a built-in compensating curve within inside the teeth. I also, in some cases, I will draw the curvature here with model analysis and follow that and do a customized curve of SPE. I'm not going to touch on that today because I wanted to spend time today to show how the teeth function. And then please sign up for the hands-on portion in October, where we'll go through this much more intricately when we have the time to do it. Or better yet, when you're done watching, send an email. So when this course is finished, you're going to get an email saying, hi, thanks for attending. Do you have any comments? In the comments section, you can say, look, I would love in 2023 a hands-on in-person course. And as restrictions and things, and we get our life back in our new normal, then if VITA hears that from you, that you want a in-person course with this topic, they hear enough of it from the population, then that gives them reason to put the course on. So then I kindly ask for you to then please respond to that follow-up email that you'll receive, say tomorrow, and please write in there that you want an in-person course like this in your territory, or we centralize it across the countries and pick some central locations. But if there's enough demand, then that gives us cause to do it. But VITA needs to hear that from you. Because we're doing our best with the camera and a webinar. We're doing our best. So what you're going to see now is this becomes the crossover point on the for the Crossbite case. And now what's happening is I'm taking that buccal cusp and I'm placing it inside the fossa. So the buccal cusp of the upper is going into the distal fossa of the lower. So that's not what we would typically see, okay? Typically, you'd see the lingual cusp go into the fossa. So let me just try to pretend. It would be more like that. And all I'm doing is I'm pushing it in now because it's Crossbite. And all I've done is just put the buccal in. It's quote unquote that simple. But, and here's the but I'm just allow me a moment to reposition the camera. And I'm going to take the pin off. So just bear with me, everyone. Now this might be a little bit challenging for me to do this on a camera. You have to imagine there's lips here and it's framed, right? And so now what happens is you have the anterior teeth, you see the first premolar, okay? And now the second premolar is getting tucked in, but it doesn't look odd. It looks like a setup, and we don't have the bottom teeth up here, which look unsightly. It's maintaining uppers on uppers, lowers on lowers, but it's achieving that crossbite that we need for function, but it's also achieving an aesthetical value here because of the emergence profile. And again, a part of my aha moment to say, wait a minute, look what I can do with this style of teeth that I couldn't do before using other concept or other types of denture teeth that have a different theory. So it's been extremely beneficial for me. Now, I did something out of muscle memory that I just did that I want to point out to you. So I heated the wax, and I heated it a little more on the buccal. So you can just see me up here. And then I tucked the tooth in out of occlusion, so I was high, okay? So you just flip and flip, so it's lower. And then what I did was I closed it down into occlusion, pushed it in, took my finger and just pushed on the neck, and the tooth finds its place into centric, and it's done. So what happens now is those buccal cusps, excuse me, the buccal cusps are within the lower fossas. And let me know. Okay, to show you what I'm doing. So I'm always just going to hit the refocus button, because when I hold this differently, it's changing the focus on the camera. So try to get a nice. So just to anyone that's never done a webinar before, it's always backwards. So I always have to think the different way of orientation to show you it's reversed in a camera. So it takes your central nervous system certainly learns. Okay, so the beauty of this shot, and if I may, I'm just going to try and do this by looking at the computer screen and not the case. You can see there's the buccal cusp in the fossa. You can see we have that little gap here, so the guiding planes aren't touching. I don't want them to. Here they are, so I'm going to have to grind that away a little bit later, because that's going to interfere. Remember the hit and slide. That's what you want to see. That's the beauty of this. So now I can use cusp teeth because I don't have that tight occlusion. I have freedom, which then, so I'm using treadwear teeth, like teeth that can crush, but they're going to function because they're not locked together. And that's the beauty of this. And that's the improvement to the patient by not giving them flat plane occlusion. I'm giving them teeth they can physically mince food with, whilst maintaining the functional limits that and the functionality of it that it requires. So that's why I was taught flat plane for patients that can't find centric or difficult cases, or I was actually taught flat ridge, flat plane teeth, mollisoft liner, automatic. And I've abandoned that type of theory. Yes, Paul.
So the question here is, if you're getting cheek biting in a class 3 setup, how do you adjust it, or what have you done incorrectly?
Okay, so look at us. We're right here on the second molars already. What a great timing question. So remember, I chatted about the pterygoid muscles. So you've got the medial and lateral pterygoid. So they run like this. We've got the masseter muscle and then the buccinator muscle. And so if you run into a cheek biting issue, so one is this. We have a couple of options, okay? So, and to the person that wrote that, Paul, can you read it again?
They said, if there is cheek biting in a class 3 setup, how do we adjust it, or what have we done incorrectly?
Okay, so my dear colleague, thank you for acknowledging when you said, what have we done incorrectly? I really want to applaud you for that statement, because what you've realized when there's cheek biting is that it wasn't set to that patient's unique needs in that area. So I didn't catch it, or I didn't recognize it, and I thought I was setting it correctly, but it wasn't for that specific situation. And sometimes that's really hard to know because, again, I'm not really saying watching that person eat and doing things that could really fine tune it. I'm also not inside their mouth watching things happen and unfold. So as I'm getting older, I'm learning more as I go to address these things. And I really wanted to acknowledge, to say, you know, thank you for acknowledging that you accept that responsibility to say, okay, what did I miss? It's, again, the patient was born this way. What did I miss on it? And that's beautiful. And that's what helps you learn more. So we have a couple of options on the cheek biting issue here on a class 3 crossbite. So I've set the second molar. So now you have some options. Option 1 is, again, dependent on where the cheek bite is located. I have option 1 is to tip the tooth out of occlusion here so that the distal cusp is out of the way. The mesial is going to hit. So the mesial buckle's hitting, but the distal buckle I can shove out of the way, and if necessary, grind out of the way if the pterygoid muscle's really tight in this area. So try to get a best, sorry, you kind of see, it's hard to do this with a camera. You can see the buckle is here, but now I took that mesial up out of the way to let that muscle slide in. I've also had to, at some cases, you know, grind half the tooth away or grind this cusp out of the way. Let me refocus that because of my assertion of the muscle groupings back here. So option 1 is tip and do something like crazy like that to just get out of the way, but I still have a contact point here. I'm still mincing here, keeping this out of the way. So that's option 1. Option 2 is so this tooth rests in there. So the buckle is in. But remember, I've got freedom, right? So I've got freedom in centric. What I can do now is grind the guiding planes and actually move the tooth more lingual. So what does that mean? I can adjust the tooth. So let me come back to these. So I'm like this, refocus. Okay, so remember, I'm looking to have this touch this. But now because of cheek biting, I need to move everything over this way. So I can take this tooth and move it over. So what do I need to do? I need to grind this guiding plane out of the way so that I'm increasing this table. Because remember, freedom and centric, so it's about 1 millimeter of freedom. So what I'm trying to do now is I'm sneaking it over to this side more, so to the lingual side. So I cut away this guiding plane so that it sits in more into that guiding plane. So I've increased the table, okay? But what that effectively lets me do is move the tooth over. So I've taken away that guiding plane and let me shove the tooth further this way. I can do that with VITA teeth without damaging the teeth because I'm only touching the guiding plane. The second thing is that the teeth are manufactured out of acrylic glass. So I don't need to polish it after because the glass particles self-polish. So it's not something that I have to take after. On a acrylic tooth, and all acrylic teeth from other manufacturers, you have to polish that after because if you leave it rough, that's not good. I don't have to be concerned with that with VITA teeth, which is why I've sort of fallen into using them. They're customizable for me, but then I don't have to worry about polishing them after so that to prevent further damage to the tooth. So we have the ability of, again, how I tip the tooth. So from a buccal lingual perspective, as I showed you on the setup, and now with these sample teeth I've showed you, or the plastic teeth, I have the freedom and centric. I'm just going to grind this more to bring this further this way. So it thins this down a little bit, but it again allows me just to shift the tooth over to create more space here for the muscle. So does that answer your question, my dear colleague? Can you type that back to Paul? That's the beauty of these teeth. So please type back to Paul and say, does that answer it? That's a couple quick ones, is you just, again, you adjust.
Yes, the question. Thank you, Mark.
Awesome. Positioning, or I just use the freedom and centric rule and just push this tooth further in. Like I said, now just showing you here on the tooth itself, and let me just use the green. Sometimes the camera has a hard time on these close shots. I just grind these guiding planes right here, and that just lets me widen that this contact point that it sits in. Whoops, I made several contact points, and I'm just scooting the whole thing over further in here because I just ground that away. It's quite simple to do, and again, I don't have to polish afterwards, so it's very beneficial for me as a practitioner, and effective in terms of the amount of time that I'm spending on the setup. So now you can see that I've already completed one side of this, and it didn't take long, and it's in Crossbite. And depending on the Crossbite case as well, for example, let's just play with this. I'll take the first molar out and show you how to set that into Crossbite if your Crossbite position is, and transfer point is right away. So again, if it has to, the buccal cusp comes into the corresponding fossa. Now, the only trick on that now is when you look from a profile, you'll see it start to hide because the crossover point. So now what I can do is this. To compensate for that, I'm going to come back to the cuspid, and what I can do is I'm going to turn the cuspid clockwise. So I'm taking and I'm turning this more. So now that I've highlighted, you can see me turn it more. So what that's going to do, and then I can take this tooth and I can actually turn it. So you'll see this profile here. I can take it, so you can see how I'm turning it. I can actually turn it. So what I'm doing is I'm exposing more of the tooth. So I'm trying to bring that in and hide it and bring that out more. So let's try and do that. And you can start to see already, I've exposed more of it. You can see it. Now you can see this slightly more. But what it doesn't do is bugger up how it sits here in the fossa. Because I have that freedom and centric concept, you have to keep in mind that then I can turn these. That's going to not work so well here. I'm always just looking at this from a linear perspective, but now I want everyone to understand that I can also turn these this way within that freedom and centric position, and I can turn the teeth in there. So whilst maintaining my contact, I'm just turning them so to create a facial profile. That's the beauty of freedom and centric that I wasn't able to achieve with other concepts and other theories. So now this is my one-stop tooth that I use on everyone to, number one, A, reduce my stress, B, try to provide a consistent product with few adjustments, that my schedule isn't full of adjustments. And it really has countered that because of this concept and what we've done here. So what I want to do now is set some of the anterior teeth. So let me back off a little bit. Paul, do we have any questions pop up?
Not so far. You're looking good.
Awesome. Thanks, Paul. Paul is an awesome hallway monitor. Thank you. Okay, so with prognathic, it's tough. I've got two sizes of lower anterior teeth. One is larger, one is smaller, and you have to kind of see what's going to work. because typically on prognathic cases, we're going to be shooting, because of this, the size of the mandible, we're really going to be setting pretty close end to end, and it depends on the situation. Now, what does that mean? Well, again, I have to circle back to how much does their jaw posture. I've watched them speak. I'm watching how much they're posturing and moving. Part of this is to say, Mark, they also have to be able to bite into the ham sandwich and get the ham. Okay, so I need to see how much that jaw postures. So on some cases, if there's not a lot of posture and we're short of room, we go more to our classic end-to-end setup, okay, where we're going to be end-to-end on the anterior teeth. I also have to watch here in my spacing and my orbicularis oris muscle and where the attachment is of how much room I have here. So what I like to do on an exam is grab their lip and see how much they fight me and how much flexibility there is. And if I stick my finger in here and they shove it out of their mouth and their lip goes tight, then I know, geez, I don't have a lot of space here. So I want to make sure that I keep that neck in so the bulk doesn't dislodge the denture. So there's no right or wrong answer to this. If there isn't a lot of posturing, then I can stay end to end, because when they bite into the sandwich, their jaw's not going to go much further, so to speak. So I can keep it end to end. Sometimes I have to bring it back ever so slightly, because I know there's a slight forward motion when they move or when they posture forward to go and bite into the sandwich, that if I went end to end, then they're going to overshoot the end to end. So I'll come back a little bit and not go, hit the focus button, not go fully end to end, but just slightly behind, so that when they come forward. So again, I'm not saying to you that, these types of cases, it's not an automatic, oh, you do 1-to-1 or 2-to-2 overbite to overchet. I really have to customize it. Now, as a dental technician sitting on a workbench, not seeing the patient and having essentially any information other than a nice work order sheet to go off of, you're going to want to keep in mind that, number one, there's a chew cycle to this. Number two, this patient functions and talks, and the jaw is going to posture. It's going to be usually a little less on a class 3 because of just the girth of the lower mandible, but there'll be some. So I would say then, if given no directive, you don't go end to end, you just go slightly behind to at least facilitate a little bit of movement, and you go from there. So you're making best educated decisions now based on what you believe is the norm for a class 3 and that patient. Difficult, but okay. If you can't tell, then you're going to try to make some best educated decisions. Keeping in mind now with some of the information that I'm providing you to show you what it quote unquote looks like then in the real mouth, based on my experiences then of working within the mouth. So from that perspective, then we want to make sure that we're allowing that orbicularis oris muscle some room to move here. We're just off end to end, just to allow some movements. So the next thing I wanted to do, since we've got half this set up, is this. Typically now, what we would, regardless of the articulator you use, this is a Protar from Cavo. You can use, if you have just a hinge articulator, it's fine. What we typically do then is we would check, and we're going to do this. And this is what we're taught in school. You do this motion here. And that's how I would check the cusps. So now that I showed you that video of that patient, what I want you to do is to take your articulator and facilitate a chew cycle. So you can do this on whichever articulator you use. You just might have to hold it differently, okay? But I want you to facilitate a chew cycle. So you know now that when they eat, there's going to be a certain cycle that they're going to go through to function and to talk, and they're going to posture. Now on a class 3, it's a little bit less, so they're going to come a little less protrusive. So that's why I didn't do a lot of end-to-end, or excuse me, very, very small amount of overbite and overjet, because the girth of the lower jaw. So what I'm trying to facilitate now is, in real life, I don't see this movement in real life. When you watch people and watch yourself, or watch your coworker at lunch here soon, they don't function like this. You're going to see them eat, and it's going to be some type of a chew cycle like this where they move and function. And that's what I want to emulate now in a setup, is this motion. So I don't check anymore like this. I move the articulator like this, because this is more inclusive and inducive of what happens in real life in that patient. So I want to take my pens now. So these are the cusps that are resting inside of the fossas. So it's not showing terribly well on the camera. Bear with me, and I need to do a quick recolor. So just one moment. Okay. So I'm checking centric. Now, let me bring this down. Okay. So now I have to take, so bear with me now, because I can't see directly. I'm using the computer screen because I've got the camera so close to the case. You can see that we're in that fossa, right? Okay, so we have some contact points. What I did not do was I did not use articulating paper, because when you put articulating paper in here, even the thin stuff, it bends, and it bends between the cusps, and you can get a wrong reading. So case in point, all you saw me do was color these cusps so that it's unrestricted when I tap in. If I take the paper and do it, so bear with me, just to show you the paper way. So I'm going to take the paper and I'm going to do it. You're going to see now it's a remarkable change in the amount of contact that's there. But I'm going to question it to say, wait a minute, was that the paper bending and giving me an erroneous reading? You saw before with the red that I had a contact here and I had a contact here. Now those have been validated with the paper. We can see that. But now I have all of these other marks that are in here. Was that the paper getting bent and manipulated so it marked it erroneously? And now I'm looking at it, making a potential grind here when I shouldn't be, because the paper was incorrect. So that's why I don't use articulating paper in the lab anymore. And you're going, what? Like, yep, I don't use articulating paper. I use the pen, because the pen gives me accuracy. The pen isn't going to lie to me and get bent and move. And give me an erroneous reading. So what I do is, again, I'm going to color the cusps that are going to be my chewing cusps. And you want to color them, right? You want to make sure that you go all over on the buccal side, because it rests fully within that fossa. So I want to make sure that I'm covering everything. Okay. And that goes tap, tap. And now you see, I've reestablished, okay, where my contact points are. Now, let me just get the wax out of there. Now what I'm going to do is I'm going to color this green. So remember, these are the freedom. I don't want the hit and slide happening. So I'm going to come in here and I'm going to color this green. So the pen that I'm using is a Staedtler non-permanent, made in Germany, non-permanent one. You can use a Sharpie, doesn't matter, so long as it's non-permanent. Okay. And now what I'm going to do is this. I'm going to come in centric and do this, and I'm not expecting to see much green. But look at that. So let me just refocus the camera. You can see there's a little bit of green right here. So again, that cusp is resting in there. So I'm going to want to take that off. Because remember, I'm not chewing over here. The contact and the chewing is going to be right in here. But now with that still in green, as I back away, now I want to do this. So remember, I want to go through a chew motion. So what happens is, remember, when I use this on an articulator, the condyles, the Bennett, all of those articulated motions, the Bennett angle, the condylar angle, that's influencing this chew cycle. But now I'm using the articulator instead of the first way I showed you. I'm going through a eating, and especially if I know they posture to one side, I concentrate on that. And now we'll come through and you can see any potential green marks. So let me put the case down so I'm not shaking. I'm going to zoom in, and now you can see the potential areas where it was interfering because of the green marks. And I'm going to show that now on the upper even more. See that? See how that got marked away? So that tells me there's an interference right there. Look at that. So I need to correct that. Okay, that's the beauty of this. This is very finite. It gives you very finite information, and that's why I love using the color-coded pens when I do this type of work, and when I do the setup, and then I'm manipulating the articulator like this. So what I wanted to show you today was freedom and centric, crossbite, prognathic, some of the theory behind it, mortar and pestle, putting a cusp into a fossa, and now showing you that here in a setup perspective, the fact that we can turn teeth to suit our needs and be able to three-dimensionally turn them as required. Now going through and showing and identifying the chewing cusps into the fossa, and then what I use to check and then grind as required to make sure that we don't have contact and issues within a chew cycle happening. So sorry, because I've been manipulating, some of the teeth are coming out. So I'm going to open this question to everyone listening. This is kind of makes sense now, where what I've done is I haven't done a crisscross method. All I've done is just put instead of the lingual in the lower fossa, I've put the buccal in, and then that maintains within a frame a proper aesthetical value for this. So now I'm not I'm reaffirming our aesthetic goals. But now in a function system, I've gone to teeth that again have tread wear so that they can mince, thus eliminating my complaint on I can't eat lettuce. And I've gone through. So I had to sort of get out of my own way here through my learning curve all these years to say I don't need a flat plane tooth because that's not helping the patient. It's making life a little easier for me treating them, but in the end, it's not helping them because they're trying to chew on flat teeth. Here, what I've done is I've now realized I can give them what I need, but because I've got freedom and freedom in centric, so bear with me here. See the wiggle? So that's me wiggling it horizontally. I've got freedom. So that compensates for what monoline teeth would provide me. But now I've given them something to chew with and mince with, so it's more effective, more efficient for them. And then now functioning within a chew cycle for them and their needs within a chew cycle. So we've got the freedom and centric. I've got the wiggle so that I know that they're functioning and they don't have to bullseye land centric each and every time. There we go. It's hard to show you on a camera. And we've got that inherent little bit of wiggle that's there. Okay. Paul, any questions that are popping up?
The only one was asking about articulating silk versus the articulating paper.
Right. So yes, I've used the silk as well. I know Candular sells it. Yeah, it's finer and it gives you less chance of an erroneous reading. Yes, because it drapes more. I just found that I migrated to this and I guess invented or thought of this way because now it really eliminates anything. It just gives me the raw data, period. And that's why I kind of went to the pen aspect. You know, silk works, yep. Less chance of there being erroneous reading, yep. Does it work? Yep. You just, again, the beauty of this is we have to discern what is an erroneous reading and what that is so that you know that you're not grinding something unnecessarily away from the tooth. So reading articulating paper is an art form, in my humble opinion. So that's why I went away from that. But the silk works, sure. You just have to make sure that you're not taking away something that still gave you an erroneous reading. Any other questions, Paul?
Let's see, someone is asking, what about anterior teeth on a class 3? How should they be set?
Okay, so with the prognathic, again, I'm going to set it with a very slight overbite and overjet, especially if I don't know the patient and I don't see the patient. I'm going to try to do that to allow that jaw posturing forward because it most likely will slightly. And then I set with a very minimal, I'm almost going to say half millimeter. Like in this instance, it's a very, very small discerning amount of overbite and overjet. Okay. Sometimes it's fully end to end. It depends on the case and the situation. So my answer to you, my dear colleague, is if you're a dental technician and you don't know the patient, don't try to go end to end, because if you go end to end and their jaw postures, then their teeth are going to fully come out of contact. If you do it slight, like half millimeter, very, very minor, because their jaw has such girth, it's probably not going to move as much as it would say in a class 1, which is why I would just do less. If you're a direct care practitioner that sees the patient, then you can ascertain that when you have them say the days of the week and the months of the year. If you're a dental technician and this is a case that's coming back for repeated issues, that's when then you can have that discussion with the doctor. If they're within your own city, you can hopefully do a site visit and meet the patient. If you can't, then you want the doctor to send a nice close-up video of the patient speaking, days of the week, months of the year, to ascertain the movement and the posturing that occurs during those phonetics. So again, when you ask me how to set teeth, I'm going to say it varies, but I've given you some pointers now to say what should you do. Because the lower jaw has fuller girth, we're expecting less movement, so end to end or slightly behind is reasonable. If I know things and have seen the patient and can ascertain it myself, then I'll know whether or not I'm fully going end to end or not, based on what I've just, again, seen clinically. So please type in the response box. Does that answer your question? So Paul can let me know and we can do some more if it doesn't.
The response is, what happens when the upper will not allow for that? Or did you already mention that?
What happens if the upper doesn't allow for what? Can you type in the box, allow for that? What does that mean?
Oh,
just so I'm understanding the question right.
More class 3.
Okay. Boy, I wish, Paul, we could just have it so that they could talk to us. Okay.
Yeah, so he's asking if the lower jaw is out even more.
Even more, then you're going end to end. Okay, then that's going to be a straight end to end position. So while Paul was talking, I'm trying to warm the teeth and facilitate what I think you're trying to ask me, is that if it's a really big mandible, and yeah, then you're going out end to end. Okay, then it's a full end to end from that position. I have, and I'm going to have to take these off and reposition my wax, run across a few cases in my life that it's so much. So bear with me while I just try to, I'm doing this off camera, so one moment, please. And I won't be able to pull up a picture of this off my database. So I'm just going to do this, a picture of the actual case, but let me just kind of show you so that this probably clears it for them. Okay, so let me sneak this in. Okay, so I ran into some cases. So you can see actually the lower is ahead. Okay, you see that? So the lower anterior is actually ahead of the upper anterior. Yes, then you do it that way. Okay, so yes, you have that flexibility and freedom. So where the lower overlaps the top, okay, and it would be very slight, but then it's the same for me where I'm going to do a chew. I'm going to pretend and do a chew cycle with that, even though the lower, just try to get the positioning here because remember it's backwards. There we go. The positioning where the lower is ahead of the upper. I'm still going to pretend and do a chew cycle of what I think, just to make sure that I don't. And then again, what you might have to do, and this is again, I apologize from the camera perspective, is because that lower overlaps, you might just have to bevel the inside of that incisal edge down a little bit to facilitate that in case there's any interference. So I like Excel because Excel has a thicker incisal edge. So it was CAD/CAM designed for strength. So I have the ability to adjust this also without really buggering the tooth too badly up. But what I'm doing then is I'm taking that incisal edge. So we have the upper tooth like this, and then the lower tooth sat just slightly ahead. Okay, so I think that's where you're going with this. So I've done that before, yes. And then where I'm saying is you have to sometimes is just right in here, touch that area ever so slightly, just to allow facilitation of movement here and posturing, should there be any, or chew cycle function. And you might just have to touch that ever so slightly. Keep the height, and you're just going on the back end of the bevel. So it's a really fine touch with a rubber wheel. So I hope that answers your question, because I think now that's what you're getting at. Okay. So can you type that to Paul, please? Paul, have you heard from them yet?
Yes. Let's see. If after setting the teeth and finish and delivering the dentures, should the patient accidentally lose any one denture, upper or lower, or break any posterior teeth, how do you remedy the situation, especially in context of the altered setup utilized in the fabrication of the dentures?
Okay, good question. This is my response. Every situation or incident, I'll call this an incident, so in case something breaks, it's telling us a story. So the question then is how to decipher that story. So my question to the patient is, can you please, as best as you can, describe how it broke, when it broke, what were the conditions of it breaking? You're relying on the patient's honesty and candor, but their interpretation of events. So again, it's like me trying to explain a yellow fire hydrant will come across differently if I'm explaining it or Paul's explaining it. You're trying to get the patient to explain how it broke, because how it broke is telling you a story. If it's a posterior tooth and the cusp is shattered, then you know that that's shattered most likely from a horizontal draw, not from vertical. So not from them closing, that's not going to shatter a cusp. It's going to happen when it's going through a chew cycle and it hit, slid, and caused a horizontal pressure on the tooth, which broke it. So then that tells you when you repair it, you need to allow more room within the freedom theory and freedom and centric within that lower fossa to allow so it doesn't hit and slide into position. If it's an anterior teeth that's breaking, how did it fracture? Did it fracture the tooth? Did it break halfway off? What that's telling you is where was the interference, and then where was the giveaway point where the tooth broke. So again, then that tells you how you have to alter that tooth within that patient's chew cycle so that it doesn't happen again. So I'm going to circle back to our other colleague that said, okay, I set it in the wrong position. And again, that's me being humble too, going, okay, I missed it. I can't know everything about everything inside someone's mouth. So it's telling us a story. How am I going to modify and correct it so that it functions within their chew cycle and their function cycle? So gosh, I've had people bring food to the office and I videotape them eating so I can modify and see how their cycle and their chew cycle functions, so as I can set the teeth better within that function. So I think that goes to the other question about patients that have, issues in terms of accidents or neuromuscular issues that have severely affected their functional limits and how their jaw functions, like due to strokes or things or muscles. I have them, I watch them, so I'm trying to envision how those teeth have to function within that muscular skeletal environment now. So I hope that answers your question again, my dear colleague, to say it tells the story. It's just don't fix it. It's okay, fix it and try to ascertain the reason why it broke, and then go back in and make a correction or free it up so it doesn't interfere and break again. Okay, Paul, any other questions?
Nope, looks like we're caught up.
Okay, everybody, so it's basically we're wrapping up because we're almost out of time. The other side of this would be set in a similar fashion. And so what I've done is I set the 6 anterior teeth first within the planed rim or my measurements to set the teeth. Then I've always set the first bicuspids, and then I go to the bottom and set again the bottoms down, either to a flat plane curved plate or a customized curve of speed, depending on your belief system and how you're doing it. Again, the course in October focuses on that a little more. Then we've set the teeth, and I've showed you now, instead of putting the lingual cusp in, all we've done is just push the tooth over and put the buccal cusp in, and then following a functional limits of the patient chewing and those aspects of how to do that. And now any corrective adjustments or selective grinding to grind the guiding plane of the tooth so that it functions without the hit and slide. So those are some of the key takeaways from this, that I can set it up without doing the crisscross method, maintaining aesthetics, and why I've have sort of found my way to this type of technique, and why it works for me and is less stressful and has cut my adjustment rate down. Question, Paul? So I was going to say, if you have any other last minute questions, please type them in now, because essentially we're wrapping up.
What about the loss of either denture?
The loss of either denture.
So you've done your custom setup, but now you've lost one of the arches.
Okay, so what happens if I lose the arch? I'm not quite sure. I apologize. Mark's daft. I'm not trying to. I'm having a hard time ascertaining the question. So if I set this up and then I.
Yeah. So you've set up the denture, custom like you're done. You've completed it, delivered it to the patient, and then they lose one of the arches.
Oh, one of the dentures.
Yes.
Right. Okay. So. Okay. And they want it replaced. So now I'm going to use the same teeth again and build that one denture, following somewhat of the notes that I took, and because I'm going to chart what I did, and then a re-examination and treatment plan. So again, when I have these teeth, I know the certain properties of them. I know where the fossas are, and that I have freedom and centric in that fossa. I would just redo that denture that was lost, for example, and make it work against this. Your wear life on these teeth is about 7 to 10 years on acrylic glass. So we've got a fairly effective and longevity life of wear life on these teeth. And even after 5 years, if I use new teeth to say a 5-year-old tooth, I know that my chewing cusps are going to get a little worn, so I'm just going to have to increase the scope of the guiding plane adjustment so that I have a little bit more freedom and centric to compensate for the wear of that other dentition. I hope that answers the question.
Yeah, sounds like it.
All right.
There's one more that says, have you ever had a class 3 where you had to set up the lower anteriors in an underbite position to the upper anteriors?
An underbite. Not off the top of my head that I've ever had to do that. typically what I'm going to see on class 3s is I'm not having a lot of overbite and overjet typically on a class 3 that I've ever experienced. I've done the ones where our one colleague said the lowers are superseding the tops. I've done a few of those in my career. I've done end to ends and slightly behind. But to say on a class 3 that, you know, I have more of like a class 2 type of situation in a class 3, not off memory that I've ever done that. But it, again, it's still going to work because I'm going to identify the patient, identify the chew cycle, identify how much envelope of function I have, and set teeth within it. So that's still going to work, to answer your question. I appreciate every person is going to be different, but I'm using teeth that allow me that flexibility here to make that work. So I've got teeth that are flexible to those different situations. I hope that answers your question. I mean, I don't recall off memory that I've done something like that, but gosh, I've done a lot of funky stuff in the last, 10, 15 years now with this type of theory in these teeth. Like I showed you just even on the video of doing an overbite of 6 or 7 millimeters, yet the thing functions like it doesn't have that, yet the patient can wear it without adhesive. So I've really pushed the limits of what I think I can get away with by the virtual understanding now of the chew cycles and freedom and centric. And that's what I wanted to pass along today to you. So I appreciate everybody's time and involvement and coming to join us today. I'm thankful for that and investing in yourself. And again, trying to make yourself that superhero for your patients and investing in yourself and in them and being better. So thank you for taking time. If you have any other further questions, type it out to Paul. Paul's going to assume control here, and he's going to show you a picture of my contact information so you can contact me privately. And to our other 2 colleagues, Paul is going to send me those questions and I'll email you back. Just allow me some time, please, to do that. So I appreciate it. And I appreciate your investment. And again, to VITA North America for supporting us. And our continued growth and our ability to, again, be that superhero to the patient. So thanks. Paul, you can assume control again.
Thanks, Mark.
You've assumed control.
Thank you, everyone, for joining us.
And remember, October 18, 19, and 20, we do this setup. You follow along with me, and we do it hands-on over 3 days, 2 hours each day.
Yes, thank you. So please, if you're interested in that, let us know, and we'll get you signed up. Again, I know a couple of you were asking about a recording of this. Yes, this was recorded. It takes us about a day or so to upload the recording. So like I said, give us till the first of next week, and then we'll have it available for you. Also, first of next week, you should also see an email about your CE credits for this course. So take a look at that.
They get uploaded to VITA North America's YouTube channel. And again, next week when you get the thank you for joining our course, do you have any feedback? If you're interested, please write to VITA to let them know I'm interested in an in-person hands-on course in 2023. Can we, if this is the city I live in, can we either do it here or can we centralize it? And then if enough of you do it, that gives VITA, again, cause and a business reason to come and do it. So you have to advocate for yourself, please, and that's okay to let VITA know that you want that. So thank you.
Absolutely. Please let us know. We're happy to put on more programs. You just tell us what you want, what you need, and where you're at, and we'll try and get something together. If you have technical questions about anything today, please call us at the help desk. Either myself or Jim will be happy to help you out. Here is our contact info. If you have any questions about any of the products you saw today, then this is a list of all the local sales reps, so you can contact them about pricing and that kind of stuff. So And that's what I have today. And I'm sorry, Mark, because I don't have your contact info here. You want to throw that up real quick?
Oh, I don't have that handy, Paul. Normally that's.
I'm sorry, my slides got messed up. I'm missing one. So well, I will send all of that. I will attach that, include it when I send out the information for the CE and the video.
Please,
Okay?
I have it. I just don't have it at my fingertips now.
Yeah,
I
I
would need
apologize.
a few
I
minutes.
don't either. I thought it was in here with the slides, and I just don't see it. So I will get
Okay.
that to everyone. Here's my info. If you have a question, please, send it to me, and I will get it to Mark. And also, I will include Mark's info when I send out the CE and the video information.
Okay,
All
that's a
right.
good
Thank
compromise.
you,
I
everyone,
like that.
for joining us today for another VITA Learning video. Thank you again
Yay.
to Mark for sharing his expertise with us. And we hope that you will join us in, what were the dates again? October
18, 19, and 20, and there's a cap on attendance because
Yep,
we
so
can only do so much. I think it's 15 or 20 people, so.
yeah, so let us know if you're interested in that. We'll get you signed up, and we'll
Awesome.
see. So thank you, everyone. Thank you, Mark, and we'll talk to you soon.
My pleasure. Thanks, everybody. Have a beautiful day, and thank you for investing in yourself. Be that superhero. Thank you.
Thanks. Bye.